We know that permanent supportive housing works in ending homelessness, and this study and the work that happened in Santa Clara County offered the opportunity just to provide more evidence to that fact. And in Santa Clara County, we use a collective, which is basically a coordinated effort with our collective goal in creating a state-of-the-art supportive housing system. That work has been underway really voraciously for the past 7 or 8 years. And the anchor of this work and the progress is our friends at the Office of Supportive Housing in the County of Santa Clara. And this work has been championed by the Santa Clara County Board of Supervisors, and in particular, Supervisor Dave Cortese. And it is really just my honor to be able to introduce Supervisor Cortese, and I would also love to introduce you as Senator-elect Cortese, recently this week, and so we're so happy to have you with us.
Thank you, Jennifer. Thank you so much for doing this first and foremost, and I'll probably explain that in just a minute, why I'm saying that at a deeper level than I usually do. Back in 2013, the idea came forward, I want to say in spring or maybe midsummer, brought forward by the nonprofits, particularly Catholic Charities at the time, who had this idea that something called social impact bonds might be a useful tool, even though it had only been tried in one other place in the country. They spoke to me completely separate from that conversation. Molly O'Neill, the public defender for the County of Santa Clara, came forward to me, asked for a meeting, and said, I think this idea of social impact bonds might be a good tool in addressing the homeless. At which point, I had the opportunity to bring in the COO, county COO at the time, Gary Graves, and one of our top attorneys, who's still one of our top attorneys at the county, Greta Hansen, and say, is this doable? We didn't know what we were dealing with, even though we had a couple of consultants talking to us at the time. And we thought, how is this going to affect our bond rating, social impact bonds? How does that affect your bond rating? That's how far off we were in terms of trying to wrap our minds around what we were doing. What we found out after talking to people is this has nothing to do with bonds or your bond rating. This was almost a misnomer. And one of the first things that the administration of the county wanted to do is sort of change the name of it so it wouldn't confuse people and start talking about the potential for a program called Pay for Success, which would be based on these same principles of social impact bonds. And of course, Destination Home got involved as usual, became, the glue that holds everybody together and keeps the city and the county working together and keeps all of our sectors working together. And that's really the story. That's really actually the story. It's almost that old saying that the process is the product in this particular case. I mean, of course, the product is the success of housing the homeless. Ultimately, that's all we're about, right? That's what we're here for. That's what Destination Home is here for. That's why everyone was approaching me and others at the county about getting this thing launched, helping people. That's the bottom line. But at a more structural level, this is really a case of the process is the product, and let me explain why. I think we all know, and we've learned, those of us particularly that are on this kind of a webinar, sophisticated enough about where money comes from, where support comes from, and what kind of assurances people are looking for that do this kind of work. And what we know is that when you can bring together the public sector, city, county, Destination Home, nonprofit, in this case, Abode Services was our first nonprofit provider, and then Destination Home shows up again there as a nonprofit, and the philanthropic community foundations, the community foundations, Soprado, Irvine Foundation. Now all of a sudden you've got 3 sectors involved. There's only one more left, folks, and that's the corporate sector. And Google came forward and others came forward from the corporate sector. And what I started to say is what I think we've all learned, and this is the perfect demonstration site for how this works, is when you have those 4 sectors involved and fully invested, and when you can tell all of them, you don't have to pay until you see success. I'm sure you'll be talking about that at a deeper level today. You don't have to pay until you see success. This isn't, here's some money, come back in 3 years and tell us if you had success. This is, here's the money, we'll put it in the bank, and you can draw it down every time you demonstrate success. That model, tying those 4 sectors together with the leadership of Destination Home and the brain power over at the county, and obviously the great work by our CBOs, particularly Abode, really created a model here that I was hoping back then would be replicated over and over and over again, that we would just start growing it exponentially, because it was that same year that Destination Home provided us with a cost study that told us the county was investing $521 million a year in not taking new approaches and using the old approaches. So thank you all for what you've done. And when I said I was hoping this would be replicated, that goes back to my opening couple of sentences where I said, I am so happy that you're doing this, because in my fear of fears, as somebody who's leading the Board of Supervisors now to go on to other things, I thought, is this one of those things that was a great idea with great success that just somehow doesn't get replicated? Not because of any fault or blame, but just because the world has so many moving parts that sometimes even the best ideas don't get replicated and expanded and talked about and webinared, right? And you're doing it now. You're taking this thread, picking it up again and saying, what's this all about? What can we do with this going forward? And again, I just want to express on behalf of the entire Board of Supervisors my gratitude to all of you for taking that leadership role. Thank you, Jen Loving, for all you've done. I've certainly enjoyed working with you over these years and seeing you deliver, especially some of those philanthropic contributions you've been able to secure over the years. So good luck to everyone. Let me know however I can be of assistance in the future. And let's go grow this stuff so we can eradicate homelessness once and for all. Thank you.
Thank you, Senator. Hopefully we can bring this statewide now, which is exciting for us. So Chi Lee is the Deputy County Executive at the County of Santa Clara. He's going to give us an overview about what Project Welcome Home is, and then we'll start in with the panel.
Thanks, Jennifer. Hello, everyone. I'll give a little bit of an overview of the project and sort of why the county thought it was critical to implement Project Welcome Home. So first, at its heart, what we're talking about is a permanent supportive housing program, deep permanent subsidies or deeply affordable housing, coupled with sort of intensive voluntary services using sort of the evidence-based models or approaches similar to other permanent supportive housing programs, housing first approach, harm reduction model, sort of a modified assertive community treatment team, and really using this program to help people who have long periods or multiple periods of homelessness and who have disabling conditions, often more than one. The idea with Project Welcome Home is also that we would begin to, as with maybe all permanent supportive housing programs, is to identify people with the highest needs and try to prioritize them for these critical services, these scarce sort of resource-intensive services. And you'll hear more about sort of the population and the operations. When we think about Project Welcome Home, it is interesting for several reasons. One of which is what Supervisor Cortese mentioned, is that we use a social impact financing model for a part of it. So this is a sort of a 6-year program, and when we think about Project Welcome Home, we really thought about it in 3 components. The first component was a contract with Abode Services to provide most of the case management and services And this $8 million or so was financed. We worked with the Reinvestment Fund, Sobrato Family Foundation, etc., to finance these services, and some of these services would be repaid if Abode Services met certain success metrics. And roughly, the key success metric, or the success metric, was a stable housing, so months of stable housing. And the goal, sort of the payments were sort of stratified in months. So like months 1 to 3 had a certain amount, months 4 to 6 had a certain amount, and the goal was to get to 12 months. That was sort of the gold standard. And so the success payments were structured to incentivize or to reward repayment success at 12 months. So that was sort of the main part of Project Welcome Home and sort of the social impact financing model that Supervisor Cortese mentioned. But it also had a couple other components. First is the housing component. We knew that, of course, none of this works without any housing subsidies or housing units. So we did set aside housing dollars, subsidy dollars specific to that. And we recognized that once people got into housing, we wanted to keep them in housing. So tying that to some type of success metric or some type of unstable funding source would be not a great idea. So we put aside housing dollars separately. And then we also had the clinical services component, right? Here, if we could have incorporated it into a pay for success model, we would have. But the key about the clinical services is that, it's matched by county. It's a combination of county general funds and federal Medi-Cal dollars for the specialty mental health system. So we knew that these clinical services were necessary for the clients, but there was no way to sort of incorporate that into the social impact financing model. So we contracted with Abode directly for those services. So when we think about Project Welcome Home, we think about these three components, and then sort of outside of the Project Welcome Home agreement, we'd had other housing resources. And then to get them started, we had a small ramp-up period outside of the 6-year period. You sort of may ask sort of like, why go through all of this? Why go through social impact financing? Permanent supportive housing sort of works, and it's been proven to work, and it's proven work here. Well, the main reason was that this is all hindsight. In 2013, we were barely getting started. The supportive housing system that we talk about today in Santa Clara County did not exist. For example, in 2015, well before when we sort of began the project, we had about 1,900 units, 1,900 people in some type of permanent supportive housing. And then now in 2019, in January 2019, we have about 3,300. So it's grown. But back then, we barely had any permanent supportive housing, and this included all permanent supportive housing, including HUD-DASH, including everything that had ever been built or funded since 2005. So it's really a new concept, and the local agencies, the county, the cities, the housing authority, were really just coming together to create a more substantive and more sophisticated supportive housing system. And even though it's been proven to work, when we proved it here, there's still a lot of questions way back when. Could it serve the hardest to serve? Could this really work for people with the greatest need? And in fact, time and time again, it should be used. It can be. It does work for those individuals, and it should be used for those individuals specifically. And then we like many places, we had a lot of questions about whether it applies locally. Everyone has a sense that even though it worked in LA or San Francisco or wherever, we're somehow different. So we just wanted to, make it clear that it applies to us and our residents as well. And then there was just a lot of opportunity for us to learn and to grow our system through a project that had significant public investment, significant private partnership, and a rigorous evaluation. And some of the challenges or opportunities I listed here. There was a question about whether we could identify those with the highest need, and if we could really outreach to them and engage them. And through this project and through the development of the supportive housing system, we have the most comprehensive study on the impact of homelessness in Santa Clara County through our homeless cost study. UCSF created a triage tool to help us identify the individuals for this program. And we, through this process, learned that we needed to have a very specific client outreach and engagement team for all of our permanent supportive housing programs to make it work. Another challenge was whether we had the data sources that were necessary and the processes that were necessary to identify individuals, report on outcomes, and in order to report on success. And amazingly, thanks to our attorneys, we were able to do that. We worked with Palantir to create a Slate, a management information system specific to this, pulling in utilization data and helping us to track the performance measures. And then finally, we were able to integrate our mental health services and funding into this program, whereas before, mental health services were operated or provided separate from our permanent supportive housing programs. Finally, for me, we still learned a lot from all of this. And maybe you'll hear later, at the time, for example, we estimated that about maybe 1% of the individuals would pass away while in the program. Well, we learned through the course of this that actual number was higher, and people have more medical needs than we anticipated. And as a result of that, we established a Hope Clinic, established and integrated a medical team through our Valley Homeless Healthcare Program into our supportive housing system to support all permanent supportive housing programs. Thank you.
Thank you, Key. Before we jump in, let me just do a quick introduction of the rest of the panel. We're so excited to have Dr. Margot Kushel with us today, Professor of Medicine and Director of the UCSF Benioff Homeless and Housing Initiative, Dr. Maria Raven, Associate Professor of Emergency Medicine and Chief of the Department of Emergency Medicine at UCSF, and Vivian Wan, who's the Chief Operating Officer at Abode Services. So Vivian, I'll ask you this first question. Abode played a critical role in implementing Project Welcome Home. So we would love to hear your on-the-ground perspective in bringing this initiative to hundreds of individuals over the study period.
Great. Thanks, Jen. And thank you for having me here today. I first want to do a little reflection. I promise I won't take too much time, but, this project has been really the privilege of a lifetime to implement, and it's largely because I've been able to work with just, the smartest, most passionate, hardest working individuals of my life. And I'm not talking about only the folks, my fellow panelists, but our amazing staff who have delivered fantastic services, and those who we've served, who we've learned a lot from along the way as well. So just an amazing group of people that we've been able to work with over the course of the last 7 years. So Abode had been working with Jen Loving and Supervisor / Senator Cortese can't give enough kudos to. I totally agree, because at the time, I think we've been working in Santa Clara County for about 5 years, and mostly on the housing side, because that's our framework. Really, we know that housing ends homelessness. So we've been working with Housing 1000, the Care Coordination Project, all of these efforts that we're just launching in Santa Clara County with Jen's leadership. And then this weird concept of pay for success or social impact bonds, came along. And of course, because we're crazy, we raised our hands and said, sure, we'll try that. So we came into this project, really looking at it like, I see some friends on the call like a full-service partnership. So for those of you who provide homeless services in the state, through MHSA funds, this idea of full-service partnership really serving people where they're at in an integrated wraparound model. So from the model perspective, what this looked like for us was a modified assertive community treatment team. What that means is a lot of folks with different disciplines, including clinical staff, people that have masters in social work or MFTs, marriage family therapists, so clinical background staff, wellness specialists. Those are people with lived experience that have either experienced homelessness themselves or through their immediate families, so really can walk with people in a different way. Harm reduction specialists, those who are specialists in addiction issues. And then we had psychiatry support for med management. At any rate, an ACT team basically is a team working closely together to make sure that the needs of each individual is served. So in this team, I think others will describe the project more, and if you read the study, at any point in time, we can serve about 134 folks. And our team is about 17 staff. To give you an idea, I think in the study it's 10 to 15 ratio. And what was a little bit different about our team than some other teams in Santa Clara County and how we built the program was really with housing as a center again. We thought deeply about not only the types of social services that people would need, but the types of housing and the varied types of housing that people would need. So we built into the program both site-based housing that we could access upon turnover of units. Thanks to the county, they brought to bear new housing that was actually in construction. And then we also knew that we needed an array of scattered site housing, meaning just housing in the community that we could rent with landlords that would be immediately. And we knew, because of our long history of serving folks experiencing chronic homelessness, that people would need more than one housing placement. So, and we found this to be true, through Dr. Kushel and Dr. Raven. They obviously found this to be true. Almost everyone moved, so over 70% of folks moved at least once. Most moved far more. I think the average was a little bit over 2. I think we had people that moved up to 8 or 9 times. So meaning that the first placement isn't always successful, and that's okay. So we wanted to make sure that we built in a lot of opportunities for individuals to be successful. So we had to build in housing staff, which, so in addition to the clinical support staff, we knew that we needed folks who would just focus on the housing, making sure that they could move individuals, making sure they collaborate with property managers, landlords. And that proved to be invaluable. We learned a lot along the way. I don't know, Jen, do you want me to go into lessons learned yet, or save those till later?
I think we'll do that. We'll do that in a little bit. How's that sound?
That sounds perfect. But yeah, that's the model, and we've been really happy to work with everyone on it.
Thank you, Vivian. So, Dr. Raven, measuring the outcomes of Project Welcome Home was, of course, key in implementing the Pay for Success model, but it also provided us a huge opportunity to advocate for these types of investments going forward. Can you share more about how you and your fellow researchers approached this study and what you see as possible?
Sure. Yeah, thanks, Jennifer. So Dr. Kushel, Margot, who's also here, my colleague at UCSF, and some others, we thought of this as a really amazing opportunity because as program evaluators, it's actually fairly rare to come into a evaluation at the very, very beginning before it's actually completely been designed. And so we were able to sort of serve as a stakeholder in the actual study design and implementation, and really bring in Vivian and Key and others to kind of figure out what would be able to provide the most rigorous evaluation, but also sort of work for the county, right, and the people that we're trying to reach. So we ended up deciding to go with, as a group, a randomized trial design. And The reason for this was because the housing units were what we would consider a limited resource. And we knew from some of the preliminary research that we had done that there was a very, very large group of individuals experiencing homelessness in Santa Clara County who would potentially qualify for those units. And so we figured, it's actually maybe the most ethical way to choose who gets these units by randomizing people, because then you have a whole group of eligible people and you're just choosing truly at random who is randomized to the intervention, which is the permanent supportive housing intervention with Abode versus the usual county services. One of the reasons we also wanted to do a randomized trial is because we're studying very, very frequent users of the healthcare system and jail who have been chronically homeless. And what we know is that previous studies of frequent utilizers, whether or not they're homeless or just frequent users of the healthcare system, if you do a pre-post study, what you will often find is that utilization drastically drops during the course of whatever intervention you have set up. And what we know is that phenomenon can often be attributed to something called regression to the mean. So when you have a lot of anything, statistically what happens over time is it just drops off towards kind of the average, even if you do nothing. And so what we knew from the literature was there were a lot of studies that showed these amazing results and huge drop-off in utilization when you look before and after. But we also knew that that probably was not exactly the case. So we thought it was really important to have a control group to compare to. So, then I guess I can just speak quickly to some of the outcomes. Again, it was a lot of group decision-making in terms of what the county felt would be really important outcomes to look at. And then obviously Margot and I lent some of our own opinions to that as well. But clearly the success outcome, which was a measurement of housing over time, sort of its own decision about exactly how to calculate that. And we can go into more details on sort of the intricacies of that, because it actually is not simple. And then the outcomes for the trial were looking at more of the utilization outcomes, comparing the intervention and control group to things like emergency department use, psychiatric emergency department use, shelter. And then, of course, we were also able to look at things like mortality and length of time in housing. So I can stop there.
We can get into this a little bit later, but, the idea of an RCT, was that unusual for this population?
It was very unusual. I think there was a lot of hesitancy at first because it feels like it could be perceived as unfair, even though when you sort of think about it, it actually is very fair as long as you have a limited amount of resources, because then you're sort of ethically allocating these limited housing units by randomizing people. I do remember one conversation we had, and I don't know if Key and Vivian and Margot, you remember this, but we kind of were thinking about this different scenarios, and if, two people that knew each other from experiencing homelessness and being in the community kind of came up to one another, and one had been offered enrollment into permanent supportive housing, whereas one had never even heard about the study. We sort of thought it would be a little bit better if people met and they had both been informed of the study and they really understood that they were just being randomized and they had a 50-50 chance of getting into either group. And when we sort of thought about that way, we kind of realized, okay, this feels like it's going to be all right. But we did have to take some important provisions, like if someone was very disappointed, if they did not get into the intervention group, because of course it would be very disappointing to know potentially that you could get immediately referred into permanent supportive housing versus just go through the usual county channels. We had to take some provisions to make sure that people had the appropriate support if they were upset.
Thank you, Maria.
Mm-hmm.
Dr. Kushel, Margot, my friend Margot, these findings build on a body of research that you in particular have been working on for years. You have done so much to advance progress for our community, people that experience homelessness, and create the will for more to be done. So what do you think are the broader implications of these findings in particular?
Thanks, Jen. It's great to be here. I think for me, there are a couple things. When Santa Clara came to us, you came to us and said, don't give us the easiest folks. help us find the hardest folks. And so I think it's really important that everyone listening knows that. And that Maria, Dr. Raver in particular, designed this incredible triage tool that looks not only for people who are really high users of services, of mental health services, psychiatric emergency department, jails, inpatient hospitalization, but people who we have reason to believe would continue being high utilizers. And we basically found more or less the 400 toughest to serve people in Santa Clara. And I think, first of all, it's pretty brave on Santa Clara's part, because I don't think that's been everyone's attitude of like, send us your hardest to find. We took advantage of the fact that people who use a lot of services use a lot of services. And so we kind of knew that these folks would pop up. They would pop up in jail. They would pop up in the psychiatric emergency department because they had incredibly high use of services. I think over the 2 years prior to enrollment, on average, they had 17 emergency department visits and 6 jail stays. I'm not remembering exactly, but like just incredibly high use of services, 5 hospitalizations. These are folks who have a lot of impairment. These are the folks who sort of the public sort of freaks out over, like, oh no, how are they ever going to be housed? And what we did is whenever they popped up, there was a tag, and this is where the technology came in, being very Silicon Valley, where, whoever was serving them on whatever portal they were on, there was like a flag that popped up and said, consider enrolling this person. So the first key findings, and thank you, Chelsea. So you can see that people have to be chronically homeless, and if you can go to the next slide, just to give you a sense, chronically homeless high users, if you go to the next slide, Chelsea, in the 2 years prior to enrollment, 5 inpatient admissions on average, 19 emergency department visits, 4 jail stays in the prior 2 years. That is just an astronomical. So it's not like one person would have 5 inpatient admissions. It's like actually some people had 40 emergency department visits, and other people have 10 inpatient admissions, but this was an average across everyone. So we can take the slide down now. So people popped up. So I think there were couple good findings. Basically, everybody agreed to be in the study. We were afraid, people often say, randomized controlled trials, people don't want to participate, you get a very, special group. Of the about 400 people who were approached, effectively 3 people didn't enroll in the trial. And basically, everyone agreed to be in it. And then the single most important finding was that everybody, of people randomized, meaning it wasn't the people who Vivian got housed. It was like the people who someone in the emergency department, they walked into the emergency department, they offered them to be in the study, they were randomized right there in the emergency department. Of those people, 86% got housed. And of the people who got housed, over 90%, they spent over 90%, I think it was 93% of their days in housing for the next, on average, 4 years. These were the toughest to house. If we can house these folks, we can house everyone. Now, some people might say, well, what about the other 14%? This is not 14% of people experiencing homelessness. This is 14% of the highest users. To give you some context, this is about 50 or 60 people in the county of Santa Clara. If we had 50 people homeless in Santa Clara County, we would all be having very different conversations about homelessness. So the top line finding, don't tell me, as politicians often do, as the general public often does, when I read the comments, which I should never read, in newspaper articles, that people don't want to be housed. Don't tell me that you can't house people. And don't tell me that people with substance use and mental health disabilities, which almost all of these folks had, can't be housed. And don't tell me that you need to treat those disabilities first. What I would say is not only can you house people with severe mental health and substance use disabilities, but you must, because that is where the engagement started. The next finding is, as Maria was sort of pointing out, we did not see this miraculous cure that, these folks are very, very sick, and it's not like when it happened, suddenly they stopped going to the hospital, suddenly everything was, went great. But what we saw was that people stayed housed, which was what we really cared about. And we saw lots of evidence of the organization of care. So what we saw is their outpatient scheduled mental health visits compared to the control group went way up. We also saw that their psychiatric emergency department visits, and speaking as a physician, those are visits that are more amenable to intervention. If you can actually get people into regular psychiatric care, they can avoid the psychiatric emergency department, and that's what we saw. That compared to the control group, their psychiatric emergency department visits went way down. They still were hospitalized quite a bit, and that's probably because these folks were already so sick by the time they went in. And unfortunately, both groups still died. Although, as Vivian and I had many conversations about this, at least they died in housing, and they did not die alone and underfunded on the street. So I think the top line things are, if we can house these folks, we can house anyone. And that I think of the services that Vivian, that Abode provided, those intensive case management services, in my mind are the disability accommodation for people with behavioral disabilities, and that's how we need to talk about it. We're not going back to a time where we don't think that people in wheelchairs deserve to have elevators, and we shouldn't think that people with psychiatric or other behavioral disabilities don't deserve to have the services that they need to help them stay housed. So I think huge success, great honor to work on it, and I hope it ends once and for all. These conversations that people don't want to be housed, not true, or that you can't house people, because if we can house the hardest to house, we can house everyone.
Yes, thank you. That's exactly right. Key, Lee, Margot mentioned this, and expand a little bit. Why did our county choose or demand, really, that we focused on the very hardest, most vulnerable folks to serve first through this project? Oftentimes it's safer to take a different approach, right, when demonstrating a project, but that was not what you decided to do. Why was that?
Yeah, what I'll add to Margot's statement is that, we were making the argument for the board and for the public that by sort of providing these intensive services to people with the highest need, that we could improve the rest of our system. Whether you determine that to mean the sort of cost avoidance or cost savings, or just sort of reducing the impact or the utilization or unnecessary utilization of the ER, the emergency psych, the psychiatric hospital. That was a critical piece that we wanted to show that this could have a change in people's unnecessary utilization. So that was a really critical piece.
Okay. Thank you.
But I also want to sort of underscore Margot's comments. We believe now the county, but also mostly at the time, people in the supportive housing world, we believe that housing is sort of foundational to recovery, and that if housing is provided, stable housing, decent, safe housing is provided, that people can overcome the harshest of disabilities, the harshest of experiences. It was important for us to demonstrate that housing individuals with the highest needs was possible, not just for the public or for others, but really for our own systems. You think the county is sort of one entity, but it's really a sort of a collection of different service systems, safety net systems that are sort of guided sometimes primarily by different sort of funding sources, regulatory policies, and sort of cultures and philosophies. So this was an important element for us, and I'm really proud of everyone who participated.
Thanks, Key. Vivian, I remember maybe about a year into this effort that you came to me, you and Lewis, and said, hey, something we did not expect was the amount of people, and Key alluded to this earlier, about the amount of people that were going to pass away in this project. And you asked for help finding trauma counseling for your team. Can you talk a little bit about that, the service model that your team, the investment that your team made, and really what those costs were as well for them?
Yeah, no, absolutely. I think Key alluded to, I believe to date we've seen 43 individuals in this program pass away. I think at the time of the study was about 37. So if you look at the total population and how caring and amazing and connected our staff are to those that we serve, this was hugely impactful to them as a team, us as a team, and honestly, as a leader, I felt helpless, at so many points because, we had folks going in, finding people who had many, many years of health conditions, and just when they got housed, shortly thereafter, we were seeing folks pass away. So we've had to, and I have some team members on this webinar too, I can't tell you how many times I got the call from Kara Carnahan, our VP of Programs, of another person passed away. Every time it hit me in the same way. And it was me that I didn't meet that person, right? And our clinicians were so close. So, yeah, it's had a huge impact on staff. We've had more turnover in this program than any other program in our agency, and we have over 60 programs in our agency. So that's saying a lot. We serve really high-need folks, and I was thinking when you were talking, Margot, Dr. Kushel, oh yeah, you're to blame for us taking the hardest of the hardest of the hard. So I remember that. It's all coming back to me. But these were really acute folks, more acute, frankly, than we, even through our vast experience of working with chronically homeless folks, had actually served all in one program. So we had immense staff turnover. We created our own teams, critical incident debrief teams within our agency to support, across teams, to support each other when just deal with the grief and loss. So we mitigated as much as possible, but we had a lot of staff turnover, and it was hard to keep folks because of the trauma that they were experiencing.
It's one of the things that was, unintended or unexpected, right? We knew people, but we did not realize when we leave people outside for so long, so many years and decades, right? The precariousness of the suffering and often really maybe the first time to actually relax. Hard to understand what that really does, right? And the trauma that people came to you with, right? Because frankly, years and years and decades of national neglect of people's lives. Dr. Raven, when you all shared this study, UCSF called it first of its kind. And then there was a few comments I saw on social media where people were saying, it's not first of its kind. We've done these studies before. What made this first of its kind? What made this study? What were the components?
Yeah, well, it is interesting because you would think that something like this had been done before. But in fact, there are very few randomized trials of provision of housing and especially permanent supportive housing. I don't know of any randomized trial, and Margot, and please correct me if anything's come up since we published this, but
one in Canada that was sort of happening concurrently, but they didn't wait, they did shorter follow-up time, but it started after it was random.
But it wasn't on the same population, correct?
It was chronically homeless with severe mental illness, not high users.
Yeah. So one of the first of its kind, I would say one of two out there that have done a randomized trial of what you would perceive to be a very, very difficult to house population. There have been trials that have looked at, using a waitlist model, a pre-post model, looking at individuals that have been in the hospital that haven't been necessarily frequent users, not necessarily categorized as chronically homeless. So really this is surprisingly one of the first studies to do this kind of rigorous trial for this very, very difficult to house population.
And so, Margot, what are the implications for that? How do we better connect the dots as we advocate for supportive housing and healthcare? How do we better connect the dots so that we're able to use this to make the case to do both, right? To bring more people inside and to build more of what we are lacking in every community, which is extremely low-income housing and permanent supportive housing.
I think we really need to work to change the narrative here. we have fallen into this narrative because people believe their eyes. They see what they see. So they see people who have obvious behavioral health, or at least have behavioral health disabilities out there on the street, and they assume that behavioral health disabilities are the cause of homelessness and that people with behavioral health disabilities can't be housed. And I think we really need to flip the narrative. Whether we do that doing science, I'm a big believer in, science is good. Obviously, I do science because I think there is a truth, and it's good to know the truth. I also don't know that it influences decision makers as much as stories do, but what we need is to have our stories support the science. That I think we have so long turned to this individual narrative because, frankly, it lets all of us off the hook. That homelessness is a massive, long-standing national policy failure. It's got three causes, basically: the dramatic shortage of extremely low-income housing, income inequality, and structural racism, and all three of those are connected to one another. No question that people with behavioral health disabilities are at higher risk of this outcome, but as I like to point out, I'm a physician, and mental health and substance use disorders don't particularly scare me. They are illnesses, they're conditions, we know how to treat them. Most people with those conditions are housed, and as you can see in the study, even those with severe conditions and chronic homelessness can easily, can be housed very successfully. I think we need to flip the narrative and make it clear that these individual elements are not what's causing homelessness, in part because for that, if we try to fix our mental health system to be perfect, we still wouldn't solve the homelessness problem. And in fact, I would argue that we can't fix our mental health system to be perfect if the mental health system is trying to solve for this massive policy failure that's homelessness. So I think we need to make a few points. One is how essential housing is for health. Like my tagline, the reason why I spent a lot of years learning the Krebs cycle, and I only spend 8 hours a week or so doing clinical medicine, and most of my time is spent on housing, is because I actually believed if I went to med school to make people healthier, the single most important thing that I could do was expand ELI housing. And so I think, I often say, housing is the best medicine. And I think we really need to move to that framework and to realize we can't actually make people healthy. I cannot make people healthy when they don't have a house. There's nothing I can do to make them healthy if they're homeless. I can try to mitigate things a little bit, but basically what we need to do is house them. And then I think we also need to flip the script and say that homelessness is not a medical problem. Homelessness is a policy failure caused by these elements that led to this dramatic shortage of ELI housing. And I think we need to take down the temperature a bit. If we can house these folks, we can house everyone. And what I like to say is everybody needs housing they can afford. Some people need services, some people don't. But that's it. It's actually not that complicated. And so we need to really get back to those basic fundamentals. And I think we need to tell the story of just how awful and devastating it is to be homeless. The median age here is a little over 50. That's what we see in the single adult homeless population, whether they're chronically homeless or not. My research has shown that people who are homeless in their 50s and 60s look a lot more like people in their 70s and 80s in the general population. So the fact that, 10% of people died or so, or 20% of people died, if you had a population of people in their 70s and 80s and followed them for 4 years, you perhaps would not be surprised that this many people died. This is the weathering effect and sort of the traumatic effect of homelessness. And we need to keep going back to, how absolutely essential housing is to thriving and to health.
I'm really glad you said, and I wrote it down, the single most important thing we can do is expand the supply of ELI housing, which is something that I know you and I both share as a core belief and what motivates us. And it always amazes me in conversations when we're talking about, building affordable housing, that people want to weigh extremely low income housing in the same sort of category as higher income affordability. And the difference really is often between life and death, equity, income inequality, the things that you're talking about that I feel like are still restrained by that mythology about homelessness as being a personal failing. And so, for you as a doctor to say those things, I think it's really important, and we all need to keep saying those things. We're going to get into audience questions in a few minutes, but before we do, why don't we just do a quick round robin? Vivian, we'll start with you. Maybe each of you can answer the same question. What was your biggest takeaway from these findings? And then where do you want us to go from here? Vivian, why don't you start, and then we'll go to Keith.
My biggest takeaway, I knew in my heart of hearts in the beginning, and it's what everyone said, everyone can be housed and can succeed. and later I hope to share some, beautiful, stories of actual folks who benefit in this program, but that we need to actually expand the amount of housing available across the board for sure, but for sure that folks who need it the most. So we need to do more of the same.
Key, what would you say?
Well, I think Margot hit it on the head that even for people for whom we think have the greatest challenges, the needs are quite simple, sort of safe, affordable housing and appropriate services. And I think the biggest takeaway for me and perhaps sort of where I want to go, and then I think sort of part of my job and my new role is to make sure or try to ensure that the services that people need are accessible. Like I mentioned in the beginning, the integration of specialty mental health services into permanent supportive housing system. That's one step. We have to integrate now our substance use treatment services, our medical services. And integration and access can look a lot of different ways, but I think that's a big piece of it. Like, I think for too long, we've sort of allowed certain barriers to access continue, and then sort of that actually has an impact on the ability of people to recover from and live meaningful lives and then sort of be successful in permanent supportive housing. And then I think that applies, that sort of focus, that lens, that frame also applies to housing development, land use policy. It's clear what people need. The services, affordable housing, especially extremely low income housing, and that's our charge now, is to figure out a way to make those things a reality.
And Margot, what about you? Biggest takeaway and where do we go?
I think the biggest takeaway is that there is really almost nobody that's too hard to house, that just about everyone can be housed. What seems to be the hardest thing to solve for is the housing, that there are mechanisms through Medicaid waiver and stuff that we could probably pay for most of the supportive services, and so that we need to just go big on housing. I think the other takeaway that we see with the death rate and we see sort of with the suffering is that we need to really not only house the hardest to house. In some ways, this was a proof of concept study so that we could finally shut out the voices saying, these folks don't want to be housed. And so it's sort of like you choose the extreme to prove the obvious for everyone else. And so I think, the work you're doing, the amazing work that Santa Clara is doing really to dramatically increase the supply of EOI housing. And I think where we go next is hopefully we've got a new administration coming in. It sure looks that way, and it gives us an opportunity to really demand that housing is on the agenda, and that that it's going to be hard to solve this without federal investment, but we need to really be advocating for that, and that we need to just expand housing, and we really need to just say to people who keep saying people don't want to be housed, just to say that's not true. We know they do. And if they say we can't house people like this, the answer is that's not true. If they say you need to get treatment before housing, the answer is that's not true. Like at the end of the day, there's truth and there's non-truth. And the truth is you can house almost everybody, no matter how significant their disabilities.
I was a caseworker for a number of years and in other direct service roles. And I can just, my first person experience is you're 100% right. Nobody is choosing this, but we have definitely marginalized and caused enough suffering that there's maybe mistrust. And really, people might not want a shelter bed, but they definitely want to come home. Okay, Dr. Raven, last word before we move into Q&A from the chat.
Sure. I mean, I couldn't say it much better than Dr. Kushel, but I think the only thing that I would add to what everyone said is, well, two things. One is that, we really shouldn't make people prove that they can cost less money in the healthcare sector in order to qualify for housing. Housing should just be a right, and there are plenty of other things we do for people in the healthcare system and in other systems that cost a lot of money, like very expensive chemotherapeutic drugs that prolong life by a couple of months. And you can think of it like long-term care facility. You can think of so many things. And, people just deserve to be housed. They shouldn't have to prove that they can somehow save money elsewhere in the system to do that. And then the last thing is, in sort of an indirect way, the private sector contributed to this because they were involved in kind of like the funding of the project. And I think we should be looking to the federal government, yes, 100%, of course. And also, frankly, I think we should be looking to the private sector. Some of these companies that are just making a ton of money to help us with this problem, especially in the areas where they're concentrated. That would be my own personal opinion.
I think we all agree with you there, Dr. Raven. So I think that Chelsea has been helping to curate some of the questions in the chat. So Chelsea, what are folks asking? And maybe we can help answer those too.
Sure. So we have one question that was answered in the chat, but I think it would be great for everyone to hear here on the panel that's listening in. A question as to if we were able to determine the difference in the number of deaths in the households and the housed individual compared to the control group.
Yeah, I'm happy to take that one because I think I posted the answer. But so as of the time of publication, clearly that number's gone up based on what Vivian said. But in the intervention group, we found, I think, 33 deaths, and in the control group, 37. Opposite. In the intervention group, 37 deaths, in the control group, 33. So fairly equal numbers. We do think that there was probably a bit more of a lag in getting the data for the control group, because in the intervention group, by and large, we had the Abode folks to tell us when someone died, and it can take a little bit longer to track someone if you're only using administrative data. So that could be the reason for the slight discrepancy in those numbers, but regardless, they're pretty equal.
And if I could add, Maria, I think it was mentioned earlier, one of the main differences is, of course, that the vast majority of those who died in the control group were housed, so 33 out of the 37, whereas of the control group, 24, out of the 33 were unhoused. So, that's what let me go to sleep at night when I got those phone calls, knowing that folks died in a safe, warm place.
Absolutely.
Thank you all. There is another timely question. We had brought up the election, and so perhaps if you kind of take a look ahead as to the potential advocacy, widespread for this type extremely low-income housing. And permanent supportive housing to the federal government moving forward? That's probably a good question for all of us, I would think.
I would say, and then I'll see what the panelists would like to say, but I'm on the board of the Santa Clara County Housing Authority. And if we were able to get a more allocation of vouchers, we could do so much more, right? And the fact that our allocation is incremental, and there are not ever an infusion of these most precious, either project-based or tenant choice vouchers. That would be I think that the housing authority, the idea at one time was that this was going to be the solution for people who needed affordable housing. And I want to say that we maybe serve 5% people who need it everywhere, right? And so I think there's a lot of work that could be done in that regard.
And that's, clearly, just expanding the housing choice voucher program, wouldn't solve everything. There's probably, we could run out of in high-cost regions like, the Bay Area. We need to also build or preserve productive use. But that said, when you look at what the federal spend would be to fully fund the housing choice voucher system, I think what a lot of people not in the housing world don't understand is that this is not an entitlement. Like, they hear of lots of problems, like you could need the help but not qualify because, the income setups are so tough, and you can get the voucher and have it hard to use because it's, private landlords sometimes you want to accept it in high-cost areas. But like putting all of that aside, only 1 in 4 households who meet the strict criteria get it. And the full federal spend to have all 4 do is not that much. I mean, I've heard different numbers batted around, but it's on like, $40, $50, $60 billion a year, which is a lot of money to think about, but for the federal government, it's a rounding error. And the fact that we don't do that is actually just unconscionable. There's such good evidence, for family homelessness. It basically ends homelessness. And again, for these most complex things, if you had a whole host, of Section 8 vouchers, you could put it together with other resources to make the housing happen. And so I really hope that there is just a big universal outcry about the lack of funding. Like, we don't say in Medicaid, like, oh, I'm sorry, 3 people already got it today. Sorry, you can't get it. Like, that's just not how that works, but it is how we view our housing assistance.
Chelsea, what else?
I am so sorry. I thought I was unmuted. Apologies, everyone. I believe this question is one for Vivian. Can you describe how you integrated medical and mental services into the program to make them more accessible?
Sure. I sort of feel like maybe one of my team planted this question, because this was this is one of the hardest part of the programs for us, actually, because the Medi-Cal is basically a federal, it's Medicaid, right? It is not a pay-for-success type of model. You actually get paid by minutes of service, not how well someone's doing, but how many minutes of service you can calculate. So it was a really hard balance for us, because, this contract was really about looking broadly at the success. What do we need to do to keep this person housed, to get them housed, to keep them housed, to meet their needs, to improve their wellness? And sometimes it didn't line up with the actual billing component. Likewise, sometimes the folks that best connect with individuals aren't also the folks that can do the high level of documentation needed for the billing systems. So we basically separated these roles to the extent that we could, not making everyone provide these billable services, and only putting that, I'll say, burden on some of the folks, because it is a really strong administrative burden. We also built our teams to make sure that we have clinical supervision, making sure that we had sort of the administrative support to really back that up. Later on, through the wisdom of our teams, we added in more compliance support so folks didn't have to figure it out on the ground. So basically, by separating the teams, really utilizing the wellness specialists, the harm reduction specialists, those type of folks, to do those service engagements that were really long. Like if you had to sit with someone at the DMV for 4 hours, because it was really important to get that, that ID or that whatever, that would be really hard for a person who had to actually bill 4 hours of billable time, whereas, a wellness specialist could do that. So honestly, it took a lot of iteration, and only I'd say in the halfway through the project is when we finally started hitting our stride a little bit more in that billing. To be honest, we learned a lot through this project as well.
Yeah, if I could just add to that, Chelsea, Vivian, you definitely hit on sort of the very important operational aspects. Just 2 quick pieces. One is sort of from the sort of county systems perspective. What we tried to do was ensure that Abode Services, the contractor for this service, this program, was able to provide those mental health services without having to rely on, a referral or a special connection to the rest of the specialty mental health system, which really means the call center and an assessment and all this type of stuff, right? So that was one piece, and as Vivian mentioned, it just took a while to sort of implement and get right. And you need some type of scale. You can't just provide all of a sudden mental health services for 10 people and just make it work. So that's one. And I think the question was about the medical services as well. And certainly, we didn't put, we didn't add some doctors and nurses to the Abode team, but we learned that We could take our Valley Homeless Healthcare team. We could expand them. We could create a clinic specifically for permanent supportive housing. And as people got enrolled and engaged in these permanent supportive housing programs, that's where they went initially for some screening, for medical services, and that really established that team as sort of their medical home. And then that becomes sort of a part of the service team, if you will, even if virtually. And then that medical team is now, over time, going to sort of make sure that as people are ready and are willing and it makes sense to sort of get connected to sort of other medical providers in our system.
Thank you. I know that we have a broad audience here, not just folks based in Silicon Valley, but I think this is an interesting question in the chat. What remains the largest gap in service delivery in Silicon Valley? And I believe that's a good question for probably the majority of the panelists here with us today.
Homes? I think I'd say homes. Margot, what would you say?
I think it's probably homes. I mean, look, services are never easy and they need to be funded, but there are mechanisms for that. I think that it's really the housing is what keeps everyone in the Bay Area and frankly nationally from bringing permanent supportive housing to scale. I think if we had the housing, we could get the services put together.
Well, when there's insufficient housing or highly unaffordable housing, it pushes people into homelessness, as we're talking about here, but it causes all sorts of other stressors. It causes all sorts of other impacts to safety net systems, to the public services throughout the county and at the city level. So definitely housing and affordable housing is the biggest thing. And when we don't have enough of it, then we have to create all sorts of programs to sort of mitigate the impacts of that. So if we had enough affordable housing, I think that would be huge.
Supervisor Cortese had mentioned the cost of homelessness study, where we learned that we were spending $500 million a year every year providing services to people while they were homeless. It wasn't solving or anything or anybody was getting better, but all this money in these services, right, were being deployed year after year after year. The homes, though, and then the work that the doctors have done on this study to show the homes have been what made the difference.
Right, and I think it's important to know that, like, when you're talking about people who are this sick, it's not like the service needs goes away. It's that the service needs work to get people, help them thrive. Like in healthcare, we certainly don't talk about healthcare saving money. Like you don't give people dialysis to save money. We don't give people antibiotics to save money. All of those things cost money, but they save lives. What's so disheartening about our spend on homelessness is, first of all, we spend a lot of money on shelter, even though we don't shelter that many people on that, and that doesn't solve homelessness. But the services, I would much rather spend money on outpatient mental health care than I would on a psychiatric ED. And so I think that it's really important to keep that in mind as well, is that we really have a lot of avoidable costs that actually not only are expensive, but really give us not great outcomes.
And there's this need to justify costs when it comes to working on poverty-related things that doesn't seem to be present when we're building trains or buying apps or doing other stuff. And so it's this real sort of interesting justification of, well, how much is too much? We get a lot of, because we are building, we passed a ballot measure, and maybe Key can talk about Measure A if we have time, building supportive housing, and people get hung up on the cost per door. Like the door cost is different when it's not like there's different hammers and nails that are being used. This is what it costs to build a house in the Bay Area. But there's some sort of mad need to justify how much is just enough to spend on super poor people. Because if it's too much for my sensibilities, then we shouldn't do it, in the face of really exorbitant spending in other ways.
Exactly, and we never calculate all the costs, right? We never calculate the costs of what it takes to, from everything like literal costs of like, sanitation and, criminal justice system and all of that. We never include that when we think about the cost, but we never really calculate the human toll and the human costs and the suffering. And in housing, I spend money for my housing. Jen, I bet you spend money for your housing. Housing costs money. There's no magic way to make that disappear.
Thank you all. We have two questions that kind of relate to each other. I'm just going to kind of read this verbatim. I believe it was mentioned earlier on that participants moving more than once was anticipated in the project. They're kind of asking what did that look like operationally, and also we're getting asked if we can share some strategies for stabilizing housing for those participants that may have had to have moved several times throughout the process. Devin, maybe you can start.
Yeah, no, absolutely. So what it looked like operationally is, because we had a full team working with folks and the housing specialists, oftentimes when people were having trouble in their unit for one reason or another, we were able to negotiate, folks moving because, again, everyone had their own lease, right? And you have to negotiate a lease just like, you and I have our lease in our apartments. So we would basically negotiate a lease and move them to another site. We built in some interim housing that we would control. We would basically master lease. And then we also, had ownership over of another site where we could move folks in if we needed to move someone quickly somewhere before we found them another leased apartment or move them into another setting. And again, some of the reasons, which is often the next question of why people moved, is sometimes there were behavioral challenges, sometimes there was some sort of domestic violence that happened. Sometimes one of the first things that happens as people move in is they feel incredibly lucky and guilty that they get to live inside and all of their friends on the streets are still outside. So they then invite their friends inside. And once people know where you live, you can't unring that bell, right? So we have to move folks as well for that. So we're able to do that, and we do a lot of that in our agency. There was a second part of that question, Chelsea, that I missed. Yeah.
Sure. Give me 1 second, please.
Chelsea, while you're looking for that, maybe I'll just add, there was a question in the chat about sort of are people interested in sort of shared housing? I think the answer is yes, right? Mainly we're talking about apartments, that people live by themselves or with their family. But I think we have to have a range of different housing types. It could be shared housing. It could be, maybe cottages in sort of different sort of more rural settings. We need all types. And some people need more intensive care even in apartments or even in a shared housing environment. Like some people who can be successful in, some people who might need assistance with daily living activities. So residential care facilities have to be a part of that continuum of housing options in a permanent supportive housing program or system.
And I think I found the question of tips around stabilizing folks in housing. That was
exactly.
Okay,
yeah.
Thanks. And then first I'm going to piggyback on Keys answering the question around shared housing. While I totally agree with him that we need all of these tools in the toolbox, I would say for the very highest need folks in Project Welcome Home, shared housing was not considered because there's a pretty high level of social skills to be able to interact with a roommate, right? And we have found that for the top of the need, that shared housing is really complicated and hasn't been super effective. And we do shared housing in other settings that is really successful. So it really depends on a lot of things. to your question around skills or tips to stabilize, often I find it's really, often we attribute challenges to the individual, and we really try to flip that at Abode and like, what can we do differently actually to make this housing more successful? And we might have placed them in a place that didn't make sense. You know, maybe they need a corner unit and not or a unit in a really smaller setting, or maybe they do need a larger supportive services umbrella. So I think we tried different sorts of housing options with folks. And then, of course, supported them with behavioral needs, you know, that really vary per each individual. So, you know, not everyone thrives in the same sort of housing. So, and sometimes we're just really wrong. Sometimes we're like, this person is going to need a full permanent supportive housing team with people on site all the time. And they don't do well there because there's a lot of other people that have a lot of similar needs. They do better out in the community in their own unit with no other person experiencing homelessness near them. So you just never know.
Thank you, Vivian. Key, I have 2 questions. You had answered one in the chat, but I think it'd be good for everyone to hear. There was a question, you know, this is a 6-year program, so what happens when it ends? And I'll tack onto that a request to briefly explain the social impact bonds and pay for success model once again.
Sure. The program will continue. The clients served here, and the program will sort of be absorbed into the rest of the permanent supportive housing system. We're sort of working on that right now. To what extent sort of success metrics play into that, I don't know yet, but certainly, you know, we're not going to end the permanent supportive housing program. So that's one. Second, just really go back to the social impact financing. So there was a sort of about $8 million worth of services over a 6-year period, and as one component of the program. And for those services, essentially Abode financed it. You know, they received loans, grants, recoverable grants from a variety of funders, the reinvestment funds, Prado Family Foundation, and others. And then as they achieved house success, basically by placing people into housing and those people stayed in housing for X number of months, then the county made payments or success payments to sort of repay those loans, those recoverable grants with interest.
Thank you very much. This is one quick question that I think we can kick to Dr. Raven. Did the emergency costs referred to in the paper include ambulance trips?
Thanks for asking. Yes. We weren't really quite able to look at costs per se, but we did look at transport along 5150s, I believe. But we didn't really get a great eye into ambulance use, in part because it was not as readily available in the data as some of the other marks that we were able to look at. But it's a really good question. I know from there are many people use the system extremely frequently, and one of the things that folks may or may not know is that the EMS system doesn't get paid on transport. So there's a real incentive for EMS to transport patients to the emergency department because that's how they get reimbursed. And so there are some programs now that are being developed sort of around community paramedicine interventions and other things where there might be other models for reimbursement that make more sense. Although I will say often the people that get brought to the emergency department really do need to be there. So.
Thank you so much. We have time for one last question that I think is a great one to leave on. The question is to how and if other counties can use this model to serve residents. And it's a question kind of focusing on the programmatic details that perhaps can be answered in a round robin here. Maybe we can start with you, Jen?
Sure. What I would say is what is blocking progress the most I think, in our different communities is really just the will. The will and the belief that this is a problem that needs to be solved collectively, that we each have a role in it, meaning it's not just a city or a county or a nonprofit's job, that it's a shared responsibility, that we each have a role in the executing the strategies. And then you have to just decide that this is, what must be done. We decided to become the rock against which all others will break, meaning we'll stay later at the meeting, or we will wait out longer, or we will fight harder, because otherwise there are just way too many reasons to not prioritize the people who frankly need our help the most. And so if a community is listening and they want to do this work, we would love to talk about like the political aspects of sort of setting up ideas on how to like put together funding. There's public and private ideas I think that we could talk about, and really then who's the leadership in communities that are really willing to make this work possible. And I really think it starts from there. And if you set that goal, so I keep talking about, setting the goal of, we're going to start with the hardest folks, and we're just going to keep going until we bring as many people home as we can. And this was part of a larger effort that has brought over 15,000 people home permanently. And in 5 years. And so, that is the will that it takes for all of us, I think, in every community, way past due. So that's what I would say. And I'll pass it to Dr. Raven.
Well, I completely agree with you. I think it is the will. I don't understand why it seems that people are, getting more and more sort of vocal about wanting to end homelessness, at least in certain communities. I know in San Francisco, where I happen to work, and in Berkeley, the problem is just completely out of control. And I'm not quite sure why we can't solve it, because there are a lot of smart people that live in these places, and, it's the home of technology, same with Santa Clara County and Silicon Valley. So I just think we need the will, and we need to be willing to make the investment on an ongoing basis. It's not a one-time cost. It is something that we need to do on an ongoing basis. And I don't really know what else to say beyond that. But I really agree with you. I think it's a matter of will, and I guess, to be realistic, and others can add on to this, there are constraints that I think people feel in terms of where to build and converting certain buildings, and the technicalities that can go into just real estate and building and transactions. And I think there are complexities there that can probably be very much worked out. I'm sure, Jennifer, you've worked on many of these, and Key and others. So I do think there's something there. I think there's a feeling in San Francisco, like, where do we go? Where else do we build? We're so jammed in already. And so in certain communities, it's sort of getting people to think about and solve that.
Key, what would you say?
Well, I think it's just a variation of the same theme that you guys were indicating. I mean, in Santa Clara County, we've been fortunate to have a team that works across agencies at all different levels. So we have created sort of the willingness, I would say, to implement such a program. And we just sort of had the right people in the right positions at the right time to remove the legal barriers, to write the right contracts, So it just takes a lot of effort to create the will, and then you need some people to sort of implement that. And, if we can be of assistance in sort of figuring out how to implement those pieces, we'd be happy to do so.
And how about Vivian, and then we'll give Margot the last word, the real last word.
Great. I think that echoing everyone, a lot of service providers and governments have come to us over the past 5 or 6 years asking this question. And we will, as the service provider, the county was working on this for a year or two before we even came into it. So that will was already there by the time that we came into it. And lined up in so many ways. Not to say that there wasn't a lot of hard work along the way on our part, but it was really that decision, that investment, was unwavering through Key's leadership, through Gary Graves, through Greta Hansen, that really pushed us through. So I think that spending time on that side of it, I'd say is what I always tell people. If ever, then what I hear a lot is, well, we don't know if we have a service provider that, could really implement. I'd be happy to talk to you. And I think it's about capacity building for your existing service providers because they're out there. It's just sometimes changing the way in which we are looking at the work. I think that one of the things that is helpful in this model is that it does help provide the full cost coverage. I didn't have to complain to Key, frankly, if I needed to pay a clinician, a master's level clinician, a whopping $65,000, right, in the Silicon Valley. A lot of service providers have to make that case over and over again. So I would, full cost contracting is what I would say as you were talking to service providers, and you will get what you pay for.
Want me to go? Echoing everything everyone said, I think that, and something Jen said really resonated. I think we need to actually believe, that poor people, often poor people of color is what we're talking about, that they deserve to be housed, they deserve dignity, they deserve safety. We spend so much money managing poverty instead of just having people have the will and to sort of say we're going to do things differently, that we can't always be in this sort of emergency response. We need to actually move. I think one thing that Santa Clara did incredibly well is this coordination. Like, this does take resources. Housing is expensive. It's why I think getting the federal government and the state involved is so absolutely essential, because it's hard for local governments to do this on their own. But a lot of what happened is that you had the will to do it. You got rid of all of these sort of moralistic beliefs of who deserves to be housed or not, and then you had everyone moving in the same direction. You really need a coordination between your housing system. You need someone who's going to make it easier to create housing, to sustain housing, to sort of work through any zoning things, and then you need a service provider. And Abode is an incredible service provider, and you guys work sort of hand in glove together, which is, I think, what's so important, because the service providers couldn't do it without the housing, and the housers couldn't do it without the service providers. And everybody just needs a little bit of political courage to say, that people are still very frightened of people, when we're talking about the severely impacted folks like we have here, that they can be housed, they should be housed. It's not that hard, and we just need to do it.
So we are at time, and I just want to thank everyone who hung in there with us today. If you have follow-up questions, Chelsea can direct you to the right person to get those answered. And I want to thank our panelists so much for carving time out of your Friday to spend time with us here at Destination Home, but also really truly for the work that you've done on this project and the lives that you saved. And hopefully for the wind that we need in our sails going forward to do a lot more of this. So thank you for your time, and thank you for your work. And I hope everyone has a really hopeful and restful weekend. Thank you so much.